Hi, I'm Heather, a senior medical resident from McMaster University. In this video, we will go through a practical approach to pneumonia. This refresher is intended for physicians who are returning to general internal medicine during the COVID-19 pandemic. This is not meant to serve as medical advice to the general population. Remember that you do not have to manage patients alone. There are many physicians in the hospital that you can call for additional assistance. Community-acquired pneumonia, or CAP, is defined as an acute infection of the pulmonary parenchyma in a patient who has acquired the infection in the community, as distinguished from hospital-acquired pneumonia. CAP is a common and potentially serious illness associated with considerable morbidity and mortality, particularly in older adult patients and those with significant comorbidities. There are many potential organisms that can cause pneumonia, but we will cover the most common ones in this refresher. When considering causes of pneumonia, it is important to think about the patient's place of residence, history of previous infections, recent antibiotic use or hospitalization, and underlying comorbidities. Frequent bacterial causes of CAP are listed on the screen. Consider the patient's risk factors for more resistant organisms, such as MRSA or Pseudomonas. These include prior isolation of these pathogens, recent hospitalization, or recent parenteral antibiotics. Viruses are also important to consider, including those listed on the screen and the novel coronavirus COVID-19. Previous guidelines recommended differentiation between community-acquired pneumonia from healthcare-associated pneumonia. The most recent American Thoracic Society and Infectious Disease Society of America 2019 guidelines suggest abandoning the term healthcare-associated pneumonia in favor of physicians covering empirically for MRSA or Pseudomonas if locally validated risk factors for either pathogen are present. When first assessing a patient, always consider airway, breathing, and circulation. Make sure to assess how much oxygen the patient is requiring and if those requirements are increasing. Look at the patient to see if they are exhibiting any signs of respiratory distress. Monitor closely for signs of hemodynamic instability, such as tachycardia, hypotension, or altered mental status. On history, typical symptoms of pneumonia include fever, pleuritic chest pain, cough with or without sputum, dyspnea, and effort intolerance. Elderly patients may have more nonspecific symptoms, such as altered mental status. Make sure to ask the patient about any comorbidities which could worsen their prognosis or cause you to consider an alternate diagnosis. On physical exam, make sure to complete a full cardiorespiratory exam. Tachypnea, tachycardia, crackles, bronchial breath sounds, dullness to percussion, or evidence of chronic respiratory disease may be present. Always keep your differential diagnosis in mind when completing the physical exam to ensure other findings are not overlooked. For patients being admitted with a presumptive diagnosis of pneumonia, the following blood work should be included: CBC with peripheral smear, renal function, and liver enzymes. This is to assess for severity of systemic disease. A troponin should be ordered to assess for acute coronary syndrome, and an arterial blood gas should be ordered to assess for both hypoxemia and hyper or hypoventilation. A chest X-ray with PA and lateral views, if possible, is critical in determining what pattern of radiographic disease might be present. In the case of COVID-19, the literature to date has demonstrated the presence of bilateral opacities with a peripheral predominance. A nasopharyngeal swab is important for the detection of respiratory viruses, including COVID-19. Consider blood cultures, especially in more severe cases or those with a history of resistant pathogens, and a sputum culture if possible, especially in the context of chronic respiratory disease. Get an ECG to rule out acute coronary syndrome or to assess for signs of right heart strain in pulmonary embolism. Consider a CTPA if tachycardic, if there's lack of consolidation on the chest X-ray, or if there's hemoptysis. A urine Legionella antigen may also be considered in severe community-acquired pneumonia. As always, consider your ABCs, airway, breathing, and circulation, IVs, oxygen and monitors, and the severity of the patient's illness when deciding where they should be admitted. There are scores to assess the severity of community-acquired pneumonia, such as the CURB-65 score and the PSI. These scores can help determine inpatient versus outpatient care. If you've decided to admit the patient to the hospital, you will need to consider whether they are admitted to a ward bed, a step-down bed, which is more highly monitored, or an ICU bed. A patient should be directly admitted to the ICU if they are hypotensive requiring vasopressors, or if they have respiratory failure requiring mechanical ventilation. A step-down bed is usually appropriate for patients requiring FiO2 of greater than 50%. Remember, it is always important to continue to monitor for increasing oxygen requirements or signs of respiratory distress or failure. For supplemental oxygen therapy, your goal should be an oxygen saturation of over 92%, or 88 to 92% in patients with underlying COPD and a history of a chronically elevated PCO2. When considering antibiotics, the vast majority of patients can be started on a beta-lactam and macrolide, which should cover most gram-positive, gram-negative, and atypical organisms which are common in CAP. A reasonable starting regimen is ceftriaxone 1 to 2 grams IV daily and azithromycin 500 milligrams IV or orally daily. An alternate regimen is a respiratory fluoroquinolone. If the patient has risk factors for MRSA, start vancomycin empirically. If the patient has risk factors for Pseudomonas, select an anti-pseudomonal beta-lactam, such as ceftazidime or tazocin. For patients with suspected aspiration, antibiotic coverage is not always indicated unless moderate to severe disease is present. If there's a high suspicion for influenza, consider empiric Tamiflu or oseltamivir 75 milligrams twice daily. Other supportive care includes IV fluids depending on volume status, short-acting bronchodilators if wheezing on exam or if there's history of underlying COPD, and chest physiotherapy if there are respiratory secretions present. No nebulized treatments are recommended as these are aerosol generating and should be avoided if possible. The ATS and IDSA 2019 guidelines do not recommend using corticosteroids in adults with non-severe CAP or severe CAP. However, they did endorse the Surviving Sepsis Campaign recommendations on the use of corticosteroids in refractory septic shock. Regarding the duration of therapy, antibiotics can be discontinued at 5 days if the patient is clinically stable. This means that they have resolution of vital sign abnormalities, the ability to eat, and they have an intact Glasgow Coma score. Longer therapy, such as 7 to 10 days, may be required if the patient does not meet the previous criteria for stability, or if they have pneumonia secondary to another infection. Thank you for watching our rapid refresher on community-acquired pneumonia. I'd like to thank my consultant author, Dr. Rebecca Amer from Respirology, and our editor, Dr. Roman Jaeschke from Critical Care. If you'd like to look at any of the resources, they are linked on this website. Thanks.